first slide, please. So the very first vaccine I want to ask about is the BCG. How relevant? What is the importance of it? Is it really protective? And are there any new studies or new developments as far as BCG is concerned?
I think we must understand the first vaccine that the baby receives is BCG. Undoubtedly the safest vaccine, I would say. More than 100 million doses given all throughout these years, and all countries have benefited. I think those who the babies have received. But first we must understand and tell the parents upfront why we are giving. Please do not use the word this is to prevent tuberculosis. You are putting your foot in the wrong place, because it is a severe form of tuberculosis, the biliary or the neurotuberculosis that we are talking about, a serious form that we are preventing. As far as how are you sure about its protectiveness, I think all of us know that number of studies have been done. The chickenpox trial from early days when I was doing my UG days, PSN, 0%, and never all eyebrows were raised to 80%. So it all depends on the population which is being studied, the strain which is being studied, and I think it all matters. But all of us know that early years it is definitely protective as far as severe form of tuberculosis is considered. You may say consider it as 86% maybe early years. As the age advances, when the child goes to adolescence, and if you ask, and the adult form of tuberculosis, will it be prevented by the BCG which was given at neonatal stage? No, I think as the age advances, the protective value of this BCG really starts coming down. So that is what is important as far as protectiveness is concerned.
Sir, any new studies, sir? Because like you said, 0 to 80%. Yes.
Yeah. Now, you must understand that BCG is not used only for protection of tuberculosis. The protection against pulmonary tuberculosis is about 52 to 58%. But against disseminated tuberculosis in early childhood, it is more than 80%. We must also remember about the stimulation of the trained innate immunity induced by BCG. Studies have shown that BCG reduces neonatal mortality by almost about 50 to 60%. It reduces deaths due to respiratory infections almost 60 to 70%. And this is because trained innate immunity. And I think in that vulnerable period when we don't have a maternal antibodies are coming down, too early to give vaccine, BCG definitely has a role in ameliorating these symptoms.
Important to understand non-tuberculous infections. So you are training the innate immunity to respond in a certain way so that any non-tuberculous infections can also be protected. And that's why our big trial, during COVID times, everybody felt that BCG probably is going to protect us from COVID also. But I think that was, it did not.
Sure. Any new development as far as the BCG vaccine is concerned?
There is a very robust BCG TB vaccine pipeline going on. About 4 vaccines in phase 3 trials. We were very excited about this VPM 1002 vaccine, which is a recombinant BCG, which, if successful, is expected to replace BCG. Unfortunately, the phase 3 trials results have just come out, and it has not, satisfied any of the primary endpoints. It has been very disappointing, and I think that vaccine is going to be shelved. The other vaccine is a live attenuated human mycobacterial vaccine. Remember, our BCG is bovine. This is called MTB-Vac. And this is being developed by Bharat. It was originally a research product BioFabric. It is now being developed by Bharat Biotech. The phase 3 studies are going to start in our country. The third vaccine is called M72 ASO1. That is, it's a fusion protein. They have taken 2 or 3 different antigens, protective antigens, fused them into a single protein, adjuvanted with ASO1. Now, this is the only vaccine which has efficacy data. In phase 2 study, it has shown an efficacy of about 47%. And this vaccine has now entered phase 3 trials. So I think at least we thought VPM 1002 will really work. It hasn't worked. I think we'll need to wait for at least another 5 years before we have any new vaccines.
So the early results were of this M72 vaccine which sir was talking about is 49.1%. That's almost 50%. It's huge. and I think recombinant vaccines. So these are a couple of vaccines which are in pipeline, probably we would be having it. And of course, I think yesterday someone talked about the BCG in bladder cancers.
The other, you took away the question. So we will wait for the pediatric update next year to hear more about these vaccines and their phase 3 trials. Any other use of BCG that we know about other than vaccination, immunization of infants? Is BCG used anywhere else?
Bladder carcinoma.
Sorry?
Bladder carcinoma.
Bladder carcinoma. And I think there was something you wanted to tell us about onco-BCG. Yesterday it was not
Onco-BCG is BCG, Mycobacterium bovis, but it has a concentration of almost 100 to 150 times of the regular BCG that we used. It is used for intravesical installation in invasive bladder cancer. Reduces the severity by about 55 to 60%. And incidentally, I have had 2 cases where onco-BCG was given mistakenly instead of the regular BCG. Fortunately, both of these kids did well without anything except a little accelerated BCG.
Moving forward. So this is for the audience. What is this? Can you identify? Anybody?
Smallpox.
And
Smallpox vaccine.
smallpox. Anything else? Any other answers? Okay, it's not for smallpox. It is for BCG. What is the?
Is it a time test?
No, it is for administration of BCG. What is this needle called? Okay, it is being used in Japan. Can we go to the next slide, please? So it's called Kuchike's needle. It is used in Japan for large-scale addition of BCG. The way you saw, you all said smallpox, so you are aware of how it functions. So it is, it was used, but then the application in real world was not. It was used in Afghanistan, and it was not thought to be as good. But it is a very quick method. What they do is they put BCG 1 drop, and then they press this needle against it and press inside. So that's the way of doing it. It was thought that it would be better, because it's going in the dermis but not going too deep and avoiding all the side effects. Next slide. So the preferred management strategy for this condition, what would you choose? Do nothing, follow up, antibiotics, anti-TB treatment, needle aspirin, surgical IND. What does this show?
BCG abscess.
Yes.
BCG lymphadenitis. So what would you do if you are dealing with a case of BCG lymphadenitis?
The size and the location, if it is small size and
Right, we go to the next slide. So this is a simple algorithm. If you see, first of all, whether it is suppurative or non-suppurative. Most of the cases are here, non-suppurative. So the thing to remember is it's a conservative treatment and follow-up and will lead to resolution. Don't jump the gun and want to give antibiotics, want to give AKT, all that is not recommended. In suppurative cases, yes, needle aspiration can be done, and if it fails, then you can do a surgical excision. We go further.
I think the only thing is it requires patience. Patients keep coming again and again. Doctor, still it is not gone. So, but you should be confident. So there are certain places where master clinic actually the treatment, it's a therapeutic intervention, but be confident and tell them. But unless and until it goes into a very suppurative state, when we may have to have. But most of the patients, as you very rightly said, follow the first part.
See, as long as the node is firm, wait. Just don't do anything. You may wait for 1 year. I've seen BCG lymph nodes persisting for 3 years also. Unless there is softening, don't intervene.
but if it is increasing in size without
Even if it is increasing, if there is no softening, wait.
really, no need for anti-TB.
No, nothing. No.
Separation is the word. So softening is the where you have to intervene.
Like Dr. Upendra rightly said that the patience is the key in our part, and to be able to convince the parents is very difficult, but that has to be done. Moving on to the polio vaccines, before I ask them to comment on the questions on the left, that is OPV or IPV, at what age and why, the question to the audience, what does this show, who is shown over here? Does anybody know? Anything about this? What is this contraption?
Ventilator, this one?
Hyperbaric. Anything else?
Ventilator?
It is against the lung
I
paralysis.
hear something.
Ventilator?
Senior pediatricians who might have seen it in their times.
It's against the respiratory paralysis due to polio.
What is it? Yes, it is an iron lung.
Iron.
And I think even when I was doing my residency, iron lung was there more as a museum piece than anything that we were using. But to your surprise, if you have not known, he's the man known as Polio Paul. He passed away in 2024, spent 70 years inside this contraption. Okay, so at the age of 6 years, he contracted polio. Why was he not put on the modern ventilators, you might think, but he was not a suitable candidate. And he went on to write books on his memoirs, on all the ordeals that he faced. After some time, he was able to teach himself to breathe for short periods where he was out on a wheelchair. Very, very interesting. Was a very popular figure on TikTok. Going
This is
further.
called the drinker's respirator.
Yes.
Drinker's
Drinker's
respirator.
respirator. Drinker is not Drinker. Drinker was the man who made this iron lung, and he was not a doctor. That's the fact to remember. So, sir, please can you tell us about OPV and IPV, at what age and why?
I think it's an extremely broad question.
Yes, very short answer.
Short. Maternally transferred polio antibodies do not last for more than a few weeks. So there is practically no protection beyond the first few weeks of life. Immunization has to start. First, birth dose of OPV. I don't know whether it is being given here. No. Incidentally, birth dose of OPV is recommended for countries who either have polio transmission or who are geographically linked to areas where polio transmission is occurring. India, we are using it.
In fact, both our countries, on one side and the other
Yes.
side.
Yes. So, birth dose of OPV in India, the seroconversion rate has been only about 18%, but it primes the memory cells and that's, sort of heightens the response to subsequent dose of OPV or IPV. The risk of VAP or VDPV is absolutely zero with the birth dose because it is being given under the cover of maternal antibodies. That is as far as the birth dose. We usually start the first dose of IPV or OPV in the routine immunization at either 6 weeks or 2 months. Most of the countries following the API schedule started at 6 weeks of age. IPV is generally given in different schedules, intramuscular and intradermal. Now, intradermal IPV is a risk mitigation strategy because your OPV does not have type 2. So, intradermal, the schedule is what the WHO has recommended is 2 ID doses with the first one given after 14 weeks of age with a minimum gap of 16 weeks between 2 doses gives over 90% seroconversion for type 1 and type 2 and about 80-82% for type 3. Okay? In India, we are using what is 6 weeks, 14 weeks and 9 months. The advantage of this 3-dose schedule, it also gives early protection and it also gives very good seroconversion because this is on base of the prime dose schedule.
This is the government schedule. So
This is the government schedule. I am talking because this is the government schedule. Now, in the IAP schedule where we are using only intramuscular, we follow 6, 10, 14 priming. We give a booster at about 15 and 18 months and a second booster between 4 and 6 years.
Then we use hexavalent.
Yes, as part of the hexavalent combination vaccine.
Absolutely.
This in short is about the polio schedule.
So I think very important to understand, we have to be careful about the use of OPV, and that's why the birth dose of, I don't know how much is the VAP incidence over here, but the 2.4 million per doses, one case of VAP is a big number, and that's why this first dose, and the beauty of that first dose is the subsequent doses take up is excellent. So that is why the local mucosal immunity it induces is great for polio. I think we have all, OPV has done its job for a country like India, otherwise it would have been difficult, but now time to complete emphasis mainly on IPV. That is what we are all doing.
And also OPV is used as part of systemic SIAs, especially in countries which had recent polio transmission, or India uses it because we have Pakistan, Afghanistan very close by, so transmission.
So you have a 246, 60 to 80 months and 4.5 years?
Yes, yes.
Okay.
But OPV is not available in the private sector, that's the thing. We go on to the next slide. So the question to the audience, when was India declared to be free of polio? When was UAE declared to be free of polio? Anybody? Any ideas? Sorry? India has not declared free? Okay.
India is
Any
declared.
others?
11th October 2011, the last case of polio was reported from, that girl's name was Rukhsar Sultana.
Rukhsar Sultana.
And 3 years after that, India was declared polio free.
Yes,
so
2014
October
was the
2014 onwards.
So, be aware that India has been declared polio free October 2014. UAE, the last case was reported in 1992.
Oh.
Yes. So, and UAE has made tremendous international eradication effort. The financials is unbelievable. As you can see here, and Emirat's polio campaign actually has been amazing in curtailing the number of polio cases in Pakistan especially. So the impact in Pakistan is amazing. As you can see, the global pledging as recent as December 2025, Abu Dhabi hosted a global event and raised $1.9 billion. They are doing a lot of work in polio eradication. Next. Okay. Coming back to the basics, some questions will be basic, some will be somewhere where you need to think a bit more. Which vaccine is most sensitive to freezing and which vaccine is most heat sensitive? I have not put all here, but whatever has been put, you can answer from that. Can I ask which one is most heat sensitive?
OPV.
OPV. Okay. Which is the most sensitive to freezing? Sorry? Penta to freezing?
MMR.
Hepatitis B.
Hepatitis B.
You
Okay.
freeze it once, it's gone.
It's gone. Next. So this is the way the sensitivity has been devised. Group A to Group F. This is very easily available. The correct storage temperature, as we know in office practice, 2 to 8 degrees centigrade. Some are most sensitive, moderately sensitive, and least sensitive. So important to know this. Next. Okay. Moving on to the Rota vaccines. Very often questions are still being asked about interchangeability of Rota vaccines. What is the latest stage when we can start it? What is the actual real world data on intussusception? What is Rotacil? Why Rotacil? Because we have a lot of patients coming from India, they would have taken Rotacil over there, and here the pediatricians would be confused as to what to do and any new vaccines expected. So these are questions to you all.
Okay, so I think let's talk of applicability to UAE. I think you have only 2 vaccines, Rotarix and Rotatec, right? So
Yes.
GSK and Merck have this. One is RSV 5 valence, rotavirus 5 valence and pentavalent and monovalent. So either of the vaccines is excellent. So the efficacy, effectiveness, safety, everything is perfect. So whichever vaccine you are using, you can very well continue to use it. The latest stage remains same. The first dose can be given up to 14 weeks and 6 days. That is what is the upper limit for the first dose. And the schedule has to be completed by 32 weeks. Very important to understand that if by any chance interchangeability, this is a common answer for all the vaccine questions that you may ask. As far as possible, try to complete the schedule with the vaccine with which you had initiated the vaccination. But in case it is not available, the patient should not lose that opportunity. And even if you had started with Rotarix, but you have first dose of Rotarix was given, second you have given with Rotatec. But remember that Rotatec we had to give 3 doses. No, that does not mean that Rotarix I had started, so only 1 dose of Rotatec. No, sorry. So now you have to complete the 3 doses of Rotatec. So whichever vaccine you had, no, that does not mean that Rotarix I had started, so only 1 dose of Rotatec. No, sorry. So now you have to complete the 3 doses of Rotatec. So whichever vaccine you had initiated, whatever vaccine subsequently you had given, I think you have to complete that schedule. Having said that, there is some change happened in 2026 in USA. And there is a conflict between CDC and IAP. CDC has felt that America is using too many vaccines And when they compared it with Denmark, they felt Denmark has lesser vaccines and still the prevalence of so many infectious diseases remains the same. So they have removed Rota as from the compulsory vaccination list to one-to-one communication, and you suggest patients and you may take it. But IAP has strongly opposed CDC and said no, nothing to it. Rota is still an important disease to be prevented, the gastroenteritis, the deaths. So that's why IAP continues to stand by the whatever recommendations we have been following. But this is what is happening on a couple of vaccines as far as, you know, the junior, what's his name, the health, Kennedy, the Robert Kennedy Jr. I think this is what is happening. So there is a conflict between CDC and IAP recommendations. But let's stick to whatever we have been using. So real world data, intussusception is not at all a problem following vaccination. So whatever was there, Rota Shield, when we had used initially, that was the problem and that vaccine was withdrawn. Subsequent, every vaccine, huge trials everywhere, even the post-marketing surveillance, no increase in those vaccine recipients vis-a-vis general population, the incidence remains same. So we did not worry about intussusception. That is very important. And not only that, I'm not only talking now, let me talk to you because some of the patients must be coming from India and they had started. So we have 2 vaccines which we, apart from these 2, of course these are available, but more importantly now we have a Bharat Biotech's vaccine and we have a Serum Institute vaccine, the Rotasil and Rotavac. Both vaccines are also equally good, effective, and also there is no non-inferiority. They have passed whatever standards were set by Rotarix and Rotatec. So even if the patient has initiated, you need not say, oh, you have taken something else, now you start off with Rotatec or Rotarix. No, that's not required. So if the patient has completed the schedule in India, let them, so certify them and they have taken Rota vaccine.
No, the question
so this is what
not if they have completed the schedule. First is, please tell us Rotasil and Rotavac, how many doses are given each, and if a patient has taken Rotasil first dose, say for example in India, then what does one do here?
There is published data about interchangeability between Rotatec and Rotarix. There is published data to show that there is interchangeability between Rotasil and Rotavac, but there is no interchangeability data between Rotarix or Rotatec and the Indian vaccines. Having said that, the bottom line what Dr. Upendra said is, if it is not possible, continue the schedule with whatever you have, but give total 3 doses.
Okay.
That's all.
Fine. We move further. So this recent, next slide please. The recent thing that happened in CDC and IAP, in relation to that, I just want to know from the audience now, how many rotavirus particles are infectious? What is the shedding density? And how long can rotavirus survive on surfaces? Anybody? Volunteers? No? Next slide please. So if your patient's dose is only 10 to 100 rotavirus particles, shedding density is 100 billion to 10 trillion, and persistence on human hands is 4 hours, environment weeks to months. And this is the reason why the rotavirus vaccine is needed. Just we cannot say that, take the hygiene, wash your hands and do this and do that and it will prevent the rotavirus diarrhea. So it's a very, very important vaccine.
That's why it is called as democratic. So, even the high-income countries and the LMIC countries are equally affected
by this. Absolutely. Next. So now, a baby has been given the first dose of DPT on 20th of April. When should the child routinely receive the second dose? In UAE scenario, when do you think he should receive the second dose?
After 2 months.
Sorry? 20th June.
16th June. 16th June.
Minimum 4 weeks.
Yes,
8
minimum
weeks.
4 weeks. But here we are giving 2, 4, 6. So we are taking 8 weeks. Next. So an interval of 8 weeks between the primary doses allows development of these successive waves of antigen-specific primary responses without interference by antibodies formed by the previous dose of that vaccine. Next. So boosters are needed for which vaccine out of all this?
I think just wait, let's go back to that earlier So if this child, can you just go back to
Previous slide.
first, the question,
Okay,
the one before
question.
this?
Yeah, are we not getting to the dates purposely? You want to, okay.
No, just 1 minute. First slide
Previous
before, yeah.
slide.
So suppose the 20th April 1st was given and 20th May, June is the right answer. But suppose the child comes on 18th of June, would you give it or not?
Yeah.
Yes,
So,
I
We
will.
can give it.
so what is the grace period?
4 days.
4 days.
So this matters to us more, not for you because you have already 8 weeks have elapsed. But in India, 6, 10, 14, it becomes very difficult. And then sometimes a day before, so the grace period is more mainly for the vaccine which is given in 4 weeks period. For 2 months, it doesn't make much of
Grace
it.
period here comes into the picture when they are traveling. So they will keep, they'll come back to you and ask. So we go back. Yes. So boosters are needed in all of the following vaccines except hepatitis A. Next. This is just to tell you about the incubation period and exposure to pathogen like vaccine antigen exposure. The primary response takes place, then you are exposed to the pathogen. Secondary immune response comes into the picture, and the incubation period. It is a long incubation period for hepatitis B versus it's a very short period for H. influenzae type B and lifelong protective antibody levels after vaccination, for example with yellow fever. Next. So we go on to PCV. PCV is a very important part of our schedule, right? So we have the Vaxneuvance, which is PCV 15, and we have Prevnar 20 available here. Which schedule is better, 3+1 versus 2+1? Again, in short answers.
Okay. We began with PCV 7, then we go up PCV 10, 13, then PCV 15, 20, there's also PCV 21. There are also plans for PCV 31, etc.
But
So
21 is
now,
not for children.
why did this change take place? Because every time a certain valency PCV was introduced, it eradicated the vaccine serotype, but non-vaccine types started increasing and they formed a major chunk of IPD. So you had to increase the valency. So right now, as far as pediatrics is concerned, we have reached up to 20. Now, how much better is PCV 20 compared to PCV 30? Studies in USA have shown that the protection against IPD increases by about 32% for children below 5 years and about 29% for those above 5 years of age. So this will be valid maybe for the next 4 or 5 years. Once serotype replacement occurs, then you may have to do something else. Now, there are basically 2 schedules of PC which is being used. 3 priming plus 1 booster, 3 priming without booster, or 2 priming with 1 booster. Now, the WHO in its recommendation has stated that when the peak incidence of IPD occurs below the age of 6 months of age, 3 priming without a booster would be the appropriate schedule. Where the peak incidence occurs towards the end of the first year or in the early second year, then a 2 priming and 1 booster is necessary. Now we must remember that in the old PCV9, an experimental vaccine which was tried in Gambia, a very extensive trial, protection against IPD without a booster remained almost for about 5 to 7 years after completion of the primary schedule. So in certain situations, a booster may not be necessary. The second thing is the longer duration of a mature PCV program that you have. Vaccine serotypes are eradicated, there is herd immunity and you no longer need protection against those serotypes. Now UK uses a single priming, 1 priming and 1 booster. So it's an evolving strategy depending upon how successful the particular immunization program is in a particular geography.
Absolutely. So we were using 3+1, we went to 3+0, we came back to 3+1, and now DOH has said 2+1, DHA is yet to update.
But basically, if you are weighing 3 priming versus 2 priming, 3 priming gives higher antibody titers against all the serotypes, but the difference is maximum for 6B and 23F. For all the others, the difference is hardly about 7%. But this difference also disappears by 1 year of age, and once you give the booster dose, whether you get 3 priming or 2 priming, there is absolutely no difference. 6B IPD has been reported more with 2 priming versus 3 priming. So that is why even in India, the IAP recommends 3 priming doses with a booster.
Thank you, sir. Next.
I think another just a very important point about PCV20. How many of you as adults have taken your Prevnar vaccine? Above 50, we are supposed to take.
Yes.
And very important to understand now, because you can follow it up with the PPSV, polysaccharide vaccine, but if you take PCV20 in adult, as you did not take the 23 valent.
Yeah,
So very important to understand the single dose of these 20 or 21 are good enough, so it need not be followed by a polysaccharide.
Fine.
3 years.
So,
You
no,
have
this
to
is
repeat it.
once you take Prevnar 20, that is enough.
That's
You don't
enough.
have to follow it up with, but if you take 15, you have to follow it up with PPSV. So, as we know, pneumococcal disease remains a substantial cause of death in children. Next, some data from local, nearby countries. So, Kuwait has shown that serotype replacement. These are the non-PCV13 strains among all age groups. Next, these are the various vaccines that were in use and are available now. Just to give you the strains that are available. Next, seroepidemiology in Oman. Serotype 22 was found to be in 5% of all isolates. Next. Yeah, so this is a question to the audience. MMR and varicella vaccine is being planned in a child. Which of the following is true? They are both live, so they cannot be given together. Give MMR first, varicella after 2 weeks. They can be given on the same day at different sites. Or minimum gap I have to maintain is 3 months. Which statement is correct?
3 weeks.
Sorry, 3 statement. Very good. Next. As I said, some will be very basic revision of facts. So interval between different vaccines. This is another question repeatedly being asked on the groups. So remember, 2 or more inactivated may be administered simultaneously or at any interval between the doses. So you need to know your list of live and list of inactivated. That is more important. Inactivated and live may be administered simultaneously or at any interval between the doses. 2 or more live injectables need 28 days minimum interval if not administered simultaneously. Next.
Dr. Kalpana, for that thing, I think that grace period is not applicable.
Which one?
28 days between the 2 live vaccines. We discussed about the grace period.
Grace period, yeah.
4 days.
For that 4 days, grace.
Grace period for live vaccines.
Live vaccines,
Can be
yeah.
reduced by 4 days.
Grace period for live vaccines is acceptable for same antigen live vaccines. If you are giving 2 varicella, you have a grace period. But if you are giving varicella and MMR, there is no grace
There
period.
is no grace.
Like 2 doses of varicella, we do not give 4 weeks apart. So
Yeah, yeah.
point to be remembered. And Anna, I'll just ask one simple question, practical question. The patient comes to you with for a MMR vaccine, goes back and after 2-3 hours remembers, oh my God, varicella was also to be given. I forgot it. So would you give it or call them again after 4 weeks?
Give it.
So what is considered as the same vaccination, in the same visit? That is what is called. So what is that same visit? Is there any duration?
Same
Is
day.
that daily?
Same day.
So it is only 1st of February. Anytime it will come. What is it?
Same day.
Same day.
Same day, 24 hours. No, 18, 12.
Morning 10 o'clock, night 10 o'clock, 1st
Yes.
February.
See, the recommendation is basically when you say same day means the same immunization session or a maximum duration interval of 6 hours, not more than that.
Okay. So, sir, going back to MMR, why some parts of India are using MR? Is there still hesitation due to fear of autism? I think you have answered autism-related question yesterday. And can it be given to those allergic to eggs?
Okay, now first, the government of India in the national schedule gives MR. They have not included mumps because mumps does not kill. Mumps doesn't lead to much hospitalization, so it's not a public health burden. The second, mumps component is not the perfect antigen. There's a lot of different, it's not the best antigen like measles and rubella. And third thing, addition of mumps increases the cost of the vaccine by 50%. There are three reasons why the government of India is not using MMR but using only MR. Now, if any vaccine containing measles or especially containing measles, either MR or MMR, if it's given below the age of 1 year, that dose should be considered as invalid. So, in NIP in India, when we give a 9 months dose, we give 2 additional doses, one at 15 months and one at 4 to 6 years. On the other hand, if you give the first dose anytime after 1 year, 2 doses are sufficient, the first dose and the second dose between 4 to 5 years. Now, we are giving the second dose for 2 reasons. One mainly is immunological, because there is a certain degree of primary vaccine failure with most of this. With mumps, it's about 5%, with rubella, it is hardly about 1%. So, when you give the second dose, everyone who had not seroconverted to the first dose seroconverts, and you get 100% seroconversion. Second is programmatic. Suppose some children have missed out the first dose, it is more cost effective to give everyone a second dose rather than doing an antibody titers for those who have not received and deciding whether they have given it off. So 2 doses are necessary. Now, mumps is a little different ballgame. Measles confers lifelong protection. Rubella, even with 1 dose, confers lifelong protection. But mumps antigen, although being a viral vaccine, has waning of immunity. There is a 40% reduction in antibody titers every year after the first 5 years. And that's the reason in countries which have very high immunization coverage rates, you have adolescent outbreaks. You see, that's why in USA they have come out with a recommendation that in outbreak situation, adolescents may receive a third, they give only a third dose of MMR vaccine.
Right, which was done in UAE recently. So yeah, and can it be given to those allergic to eggs?
Yes, it can very well be given. Though it is cultured on cheek embryo culture cells, still the amount of egg protein is minimal, negligible. So that's why you need not worry, need not ask, need not take any precaution. But as routine precaution, we ask every patient to wait for 15-20 minutes after the session, that's fine. But you need not worry. I think only the yellow fever and some of the influenza vaccines had it, but otherwise none of the vaccines right now we worry about egg allergy and did not ask this question.
Right, next. So, varicella vaccine, should it be mandatory or recommended?
So, varicella again, I think whatever complications all of us have seen, I think each one of us seen from necrotizing fasciitis, sometimes cerebellitis, aseptic meningitis, all of us have seen such complications. But death following varicella is still not, a big problem. And as sir said, for mumps, the government considers morbidity is not an issue. Tell us about mortality and we'll include it. Same thing happens, so that's why still Government of India has not included varicella in the general government UIP program. But as a pediatrician, every child sitting in front of me is precious for me as well as the parents, and that's why I should strongly recommend, because all of us know that it is completely preventable. The outbreak which can cause because of varicella, the school absenteeism and the way it spreads in the school is enormous. So I think we all must give, every child deserves to get varicella vaccine. And we need to give 2 doses. I think that is very important to understand. If you are giving 2 doses, so at least 3 months apart, but suppose you have given the first one at 15 to 18 months, the second one can be given at 4.5 years. That is what the general recommendation, but the minimum period has to be minimum 12 weeks. A varicella vaccine is important, it has to be given, and we already know that it's a live vaccine. And so you need not deliberate more on mandatory or recommended. I think we did not use such words, but must strongly tell our parents to take this vaccine.
Exactly. To the audience, the picture here is the hand of a neonate. What does it show? Okay, it is a bullous form of varicella, very rare. We will not get into the neonatal management and stuff. Next, the picture here is the hand of a neonate. What does it show? Okay, it is a bullous form of varicella, very rare. We will not get into the neonatal management and stuff. Next.
But very important to understand, if the mother gets it in those that dangerous period of 72 hours to 4 days before you had it. So I think that's why we ensure that all mothers prospective, they're planning pregnancy, varicella MMR vaccine is a must. I think that's very important to understand. Because once they conceive, we say no live vaccine. So very important to tell wherever you have opportunity.
Right. So you are in a busy OPD. You've just administered pentavalent vaccine varicella and MMR vaccine to an 18-month toddler. On their way out, casually mother informed him that the child was treated for MIS about 2 months back with IVIG and steroids. Now, what do you make of it? Are all the vaccines valid? Are all invalid? Only MMR and varicella are valid, or only Pentaxim is valid?
Pentaxim is valid.
Sorry?
Only Pentaxim is valid.
Four.
Four.
Four? Sir, what did you say?
I think the audience is right. It is 4. Now, we must remember that when immunoglobulins or blood products are administered, most of these products have antibodies against the common vaccine preventable diseases, and these antibodies are going to interfere with the take of live viral vaccines. How long is it going to interfere depends upon the concentration of those antibodies. Now let's take immunoglobulins, IV immunoglobulins. I mean, routinely replacement therapy and all, you give 400 milligram per kilogram. Kawasaki will give 2 grams per kilogram. So if it is 400 milligram per kilogram, you will wait for 9 months. If it is 1 gram per kilogram, 10. If it is 2 grams per kilogram, you will wait for 11 months before giving. So in this case, the next dose has to be given 11 months after the last dose of the IV immunoglobulin was given. As far as inactivated vaccines, some amount of blunting of the immune response occurs, but almost all of them seroconvert. So protection will be there, but antibody titers will be lower. So there is no restriction on the use of inactivated vaccines. But when you are using live, you have to be careful. Remember, whole blood, 5 months, packed cells, unwashed. Washed RBCs, you don't have no interval. But if you get unwashed or even leukocyte depleted, you have to wait for at least about 6 months. Even when you give things like rabies immunoglobulin, you have to wait for 5 to 6 months. I mean, there's a CDC chart on this. You can always take
chart here. And going to the next slide. Next, yeah, so there is a chart available from DHA which goes into more details for some of them. Easily available on the DHA site. You can go and refer to it. Next.
I'll just make one comment. I think a practical instruction to all my colleagues. Whenever we have a Kawasaki and we have used, or suppose any of these products, I think make a bold mention, because the child may not come to you. In Mumbai, he may go to Bangalore to Dr. Kasi, and at that time nobody would remember. So if we put in bold that IVIG 2 gram per kilogram received on this date, no live vaccine till, and you calculate the date and put it 11 months, I think parents will understand, and the pediatricians who they go to, I think we should all be benefited by that. Unnecessarily, otherwise, nobody knows that. It's very easy to forget it completely after 7 to 8 months.
It's very important.
You all remember the 5 questions to be asked.
Yeah.
You all attended yesterday. Recapitulate which are the 5 questions to be asked before
The dose.
Okay, anyway, I think, remember, a pre-vaccination questionnaire has to be there before every vaccine. And just those 5 questions, I think we can discuss later on. You will not land up in situations like this.
Thank you. So moving on to typhoid, again we have only typhoid VI here, so which needs booster. We need to know it from you. How often, until what age? This is the question parents always ask us. If you say boosters needed, then what age should I keep on doing these boosters?
I think first of all, I would recommend strongly to talk to DHA and ensure that typhoid conjugate vaccine becomes
typhoid is not yet a part of.
Okay, it's not a big public health problem. All right, then it's a different story. Otherwise, I think the conjugate vaccine scores much above than this. Now we have stopped. In fact, I don't even know whether it is available typhoid we have, so we don't
It is
have
available. Some of them come back to us.
the polysaccharide. But then what is important to understand the same problems of polysaccharide vaccine. You cannot keep giving the boosters again and again, because at the most 1 booster after 3 years is what is recommended, because the first dose itself has 40 to 60% I think efficacy of typhoid VI when it is considered in clinical efficacy. But then you may have to give 1 dose, but you just cannot go on repeating every 3 to 4 years the dose. So I think 1 is at the most, I would say, you can give it. But I think TCV would be the answer for the real prevention of typhoid conjugate vaccine. There also, we have debates about whether to give 2nd dose, but at least 1 dose is enough.
Now, when the child is traveling to an endemic area, he has taken 2 doses, but the last dose was before 5 years. Then still should be.
See, we are worried about repeated doses of polysaccharide vaccine because of the risk of hyporesponsiveness. Hyporesponsiveness is maximum for pneumococcal, less with meningococcal, and is not being very commonly described with typhoid vaccines. So you can probably give, 2-3 doses in these situations, definite additional dose if it's 3 or more years after the last dose of the polysaccharide vaccine.
Next. Moving on to the meningococcal vaccines, as you know, this I have written about Men-B specifically, but Men-ACWY is a recent addition to the national schedule here, so now that problem will not be there. We have to give it and we will not have to discuss it for a long period. So how important is Men-B? This is the one in orange, shows you the prevalence of the serotype B in all these countries. Next. Yeah, so sir, your take on the meningococcal B, or rather let's put it this way, before a country adopts the national schedule, within the national schedule, what is the cutoff? But this is this sum of the data.
59, 50, 51, 32, so all qualify as far as WHO's, oh my god, expertise about.
Yeah, I think it's surprising as far as India is concerned. Over 87% of all isolates are type A. Type A is just non-existent in our country. We see
So
some
there are
of
some
W
reports from India also.
Some sporadic.
extremely uncommon. We see predominantly A. We see in pilgrims who have come from Saudi, the W135 also.
Right. Going ahead, next. So this is from Saudi. Next. So recommendation from DHA, it is said to be a shared clinical decision making at the moment for meningococcal B. Adolescents and young adults 16 to 23, preferred is 16 to 18, and 2-dose series. Now 2-dose series, it was earlier 1 month apart. I think recent there has been a change and they have increased the interval to 6 months.
6 months.
So that is the.
There is one more brand you have mentioned about
We have Bexero over here. Remember is not available.
Remember is by Pfizer.
Yeah,
Pfizer. Incidentally, interesting story about Men-B. Men-B has molecular memory with human neuronal cells. So whatever vaccines were tried initially invariably landed up with encephalitis, meningoencephalitis, etc. in the study population in animals. It was only with the advent of a very modern technique called reverse vaccinology that it was possible for a Men-B vaccine to be produced. Now generally reverse vaccinology is very interesting. What they do is they isolate all the genes responsible for producing whatever antibodies are produced by that particular bug. They look at those antibodies for their properties, so they choose those genes, antibodies which are predominantly extracellular, membrane bound, neutralizing. Based on that, of over 3,000 antigens, they narrowed down to 7. When they looked at human studies in humans, they narrowed it down to 4. Out of that, they used 2 to produce this vaccine. And today now, reverse vaccinology is the starting point for all new vaccines. It's become standard now.
Right. Next.
So you guys are giving the regular conjugate pneumococcal vaccine Menacro or Menvio routinely?
Yes. So Bexero, this is still not a routine, but we do offer it, and it depends on the
I think in India what we do is we have demand only for the adolescent vaccines when they are especially going to the US universities.
Absolutely.
So
that is there here as well. So
and secondly, I think complement deficiencies and functional and anatomic asthenia. These are the 2 situations where we do.
Next. So now coming to HPV vaccine, is it a game changer? And is it better to administer it to young children?
Yes. I think HPV is one vaccine. You see, we had hepatitis B also. Hepatitis also causes cancer, but hepatic cancer has many causes. Cervical cancer, almost all cases of cervical cancer are caused by HPV. So theoretically, if you can prevent HPV, you can prevent all cervical cancer. There is no serotype replacement in cervical cancers. But unfortunately, it's not possible to include all the strains. So even HPV-9 in India covers 98% of the strains, whereas HPV-4 covers about 83.5%. I mean, the vaccine were moved very slowly in the initial years since introduction, but now I think ever since the WHO has taken it as a part of its project to prevent cervical cancer, and even in India, the government of India is planning to introduce it in the NIP as a school-based program for girls between 9 and 11 years. It has gained popularity and now it is moving very well. We have a 4-valent and we have a 9-valent. Do you have a 4-valent here or no?
9-valent is more.
9-valent is more common. Obviously, the better vaccine. In India, we have a choice of 4 and 9. And in 4 also, we have the Serum Institute 4, which is, I mean, half the cost of the MSD 4-valent vaccine. Now, it is imperative that we give between 9 and 14 years. There are many reasons for that. One, you require one less dose.
Yes.
Okay? I'm looking at the standard schedule. Now, studies where they did bridging studies of immunogenicity between 9 and 14 years and 15 to 26 years, those between 9 to 14 years, the antibody titers almost 10 to 100 times higher than that found in 15 to 26. So your immune response is far superior when you give between 9 and 14 years. Now we have population level data from Sweden. Sweden has been implemented almost for the past 10 or 12 years. And now they looked at the incidence of cervical cancer or CIN3+, according to the age of vaccination. And they have found that those who received the vaccine between 10 and 14 years had the least incidence. And those who received the vaccine after 25 years, there's practically no protective efficacy. So it is imperative that we have to give it between 9 and 14. You can't postpone it. It has no relation to sexual maturity, it has no relation to puberty, nothing. Give 9 to 14 years, it should be given.
So as you very rightly said, it is indeed a game changer. And the onus is on us as pediatricians to counsel parents properly. And I think now every patient that comes to us, they take it. There are a couple of questions they be asked. But I have seen almost no refusals for the vaccine the moment it comes from pediatricians now. And secondly, I think we have to, so I think in the major big cities and probably school-based program can be implemented here if it can be done, because the larger population gets, vaccine. Of course, the males also, we have the male vaccine also. And I think 9-valent is there, which is the top of the, all. And then 4 and 9 we are using because there is a huge cost difference between the Gardasil 9 and vis-a-vis 4 as well as the Vaccinum Institute's vaccine. But still we do recommend it and we must use it.
Yeah, DHA, DOH have school-based programs
There is
here.
a strong need for HPV vaccine in males as well.
Yes.
Because HPV also causes anal cancers, penile cancers and oropharyngeal cancers. And after all, who gives the HPV to the female? It's the male. If the male doesn't have it, it cannot spread to the female. So it's very important for herd immunity also. And we must remember that in males, there is practically no protection against subsequent infection following one natural infection. So you definitely need the vaccine.
I think the game changer is going to be another thing. The number of doses are going to reduce drastically. Now in UK, they give single dose between 12 to 25 years of age. So that is very important to understand. Only for immunocompromised they have the complete dose schedule. Otherwise, imagine if we are going to use a single dose schedule of HPV vaccine, I am sure that the cost effectiveness, the larger area population being covered, everything will be taken care of. So I think let's look forward for the day that every one of us has a single dose vaccine schedule coming into countries.
Yeah. So like Sir rightly said, it's not only the cervical cancer, it has gone to play in a lot of cancers. Next. This is the cases of HPV-related cancers diagnosed in males and females around the world every year. Males is highlighted because we should not forget the boys. Next. And it is estimated to cause, HPV per se, is estimated to cause up to 4.5% of all new cancers cases worldwide. Next. And this is the global burden of HPV-related cancers in males and females. Next. Yeah, so we all know about this, and I think why parents are more receptive to this is the minute you say the word cancer, it is scary to everybody. So introduce it, they have certain basic questions, you answer those and they are ready for it. Next. So 9-valent, as he rightly pointed out, has a 2-dose schedule, 6 months gap, Next. And this is where we come in. It was thought that 24% opted for it without recommendation, whereas with recommendation it went up to 60, but in your own experience you would know that the percentage is much higher. Next.
I think here you will have just one interruption, that a patient may have taken a Gardasil 4 from me and has come to Dubai to complete the schedule. So what would you do? I think you did not restart the schedule, that is very important to understand, and complete as per the age recommendation. So suppose the 9 to 14, first dose taken here, so you may give the second dose of Gardasil 9 over here. The child has come after 15 years, maybe you need to have the 3 doses as per our regular schedule. I think we did not tell them that you have to start afresh.
Yeah, because as now literature points it in, 1 dose is quite supposed to be protective. So yeah. So there's another question for the audience. A 4-year-old boy received the first dose of inactivated influenza vaccine in 2023. No comorbidities, otherwise healthy. He comes back to you in 2024. You receive 1 dose in 2023. You give him 1 dose or you give him 2 doses?
1 dose.
1 dose? 2 doses?
1 dose.
The recommendation is, if any child below the age of 8 completed years has received 2 or more doses in his lifetime, the 2 doses need not be given in the same season. He needs to receive only 1 dose in subsequent years. But if he has received only 1 dose, even if he comes in the next season, he has to receive 2 doses. That is the standard recommendation.
Okay. Next.
Yes, I'm saying.
We don't talk much about live vaccine because some of the live vaccine use is not very popular, except in UK there is a school-based live viral vaccination program.
Started here.
As far as live vaccines is concerned, I do not know whether it's available here, but the one available in India is marketed by Cipla. It's based on a cold-adapted Russian strain of the influenza vaccine, where it's only a single dose irrespective of age. The live attenuated vaccine, the nasal vaccine.
Not yet very popular. How do we plan vaccination in an immunocompromised child and its SIDS?
So immunocompromised is a huge, broad terminology. And we may have anything, a T-cell defect, a B-cell defect, a child taking steroids, a child who has taken IVIG, so many things, bone marrow transplant, so many things, stem cell transplant. So all these patients, you may consider them as leukemia therapy. So all these come under an umbrella of immunocompromised child. I think talking about SIDS is important, child, the other members in the family. 3 vaccines we need to be careful. I think no OPV for the child, the sibling should not take, he should all have IPV. The child who has taken a rotavirus vaccine, suppose I am an immunocompromised child and my sibling has taken rotavirus vaccine. If following rotavirus vaccine there is a diarrhea, the family needs to be extremely careful about hand hygiene because there is a possibility of transfer to this child. So though vaccine is recommended in that child, but let's be careful about that part. And thirdly, varicella is another thing that sometimes you may develop lesions, though the other child can definitely take that vaccine. But suppose he takes this, other child needs to be protected. So these are the vaccines where otherwise all age recommended vaccination for the sibling is allowed. And when we talk about the child, affected child, I think it's every condition will have its entire different schedule.
Exactly. So as I put some slides in between on T lymphocyte deficiencies, complement deficiencies and phagocytic dysfunction. We have certain criteria. Obviously, we spoke
different schedule.
Exactly. So as I put some slides in between on T lymphocyte deficiencies, complement deficiencies and phagocytic dysfunction. We have certain criteria. Obviously, we spoke earlier about some of them. The fact to remember, suppose a child undergoes bone marrow transplant. What do? He's received certain vaccinations.
Everything is washed out.
Yes.
Before that.
So the fact to remember is everything is washed out. So this generally comes to you even from the hemato-oncologist. You must have come across these cases. Next. Okay, question to the audience. Herd immunity seen with all the following pathogens except
Rabies.
polio, pneumococcal, rabies or measles?
Rabies.
Why? Actually the answer is right there. So it's possible only for pathogens who do not have a non-human host. So that is why. Next.
I just did, I think one thing, I was just about to talk about.
Right. So monoclonal antibodies and vaccination during treatment with biologicals?
I think there are two situations wherein the patient comes to us, the child himself or the pregnant mother. I think we need to be very careful because now the psoriasis, the inflammatory bowel diseases, all are on all-time high, and many of the mothers are taking infliximab, rituximab, and it all depends on what drug, in which part of pregnancy, what was the dosage, duration, everything matters. But remember, the transplacental transfer is maximum in the second and third trimester, especially if you are giving drugs like rituximab or infliximab, and then it goes on to the baby. So no live vaccines at all, completely, because B cell is 0. So no live vaccine to this child up to 12 months. Very important to understand. And inactivated vaccines also up to 6 months we did not do. Some people recommend, some bodies recommend doing a CD20 count and then starting the vaccination schedule. But let's not get into that. But at least remember the broad outline that no live vaccine for 12 months, no inactivated vaccines for 6 months. Especially if the mother has taken it in the second and third trimester.
I will give you a simple way of remembering this. Please remember, monoclonal antibodies target a single cytokine. It does not cause general immune suppression like steroids. In general, complete live vaccines 4 weeks before therapy. You can start live vaccines 4 weeks after stopping therapy. Except T-cell related, like etanercept, you wait for 3 months after completion. Rituximab, you will wait for 6 months. There are certain monoclonal antibodies like omalizumab which acts against IL-5, which is IgE. IgE has absolutely no role in the immune response to vaccines. So in using drugs like omalizumab, there is no interval at all. You can give it even during therapy. I mean, Australian, please go to this Australian handbook on immunization. It has a beautiful chart which gives all this. I mean, you can't remember these things. I think you just got to keep the chart in front of you, and every time you get a case, refer to the chart and then decide what it is.
Sometimes we doctors hesitate to do that. Lawyers immediately take out the books and refer in front of the client, but if we start opening up somewhere, our ego gets...
No, not our ego also, it is the parent's perception, doctor does not
know.
Next. So, do we have dengue vaccine available, and what about malaria vaccine?
Yeah, dengue vaccine is it's not. I'm sorry, it's not available, but it's round the corner and will get introduced in India very soon. So we have two types of vaccines, which are dengue vaccine was the first vaccine which was introduced, and you all must understand that there was a basic difference between the dengue vaccine and Qdenga, which is by Takeda. So these are the two vaccines which are right now in the world in use. And what is important to understand, the dengue vaccine is that CY, both are chimeric vaccines, but in the first one, dengue vaccine, which was by Sanofi, they have used the yellow fever 17D as a backbone on which there are certain non-structural structural antigens of the dengue virus have been integrated and it is in use. But then in Philippines, there was a serious setback to this vaccine when it was given to the seronegative children in 2017. And many of them, because this vaccine itself caused antibody-dependent enhancement, what is known as, because dengue vaccine, whatever, the dengue infection by any virus, it gives only homotypic production. So we know that we have then 1, 2, 3, 4, but then 1 does, then 2 does not protect me from then 3, then 4. So practically everybody can get 4 times dengue, though in practice at the most 2 times it is what is known. But what this vaccine was doing, this vaccine was sensitizing, these antibodies were non-neutralizing or sub-neutralizing kind of antibodies. And when these children subsequently actually got dengue infection, they just took it along and presented to the FC receptor presenting cells of macrophages, and there is smooth entry. Come, let me take you inside the cell, and then oh my God! So this was a big problem, and not only. Oh, thank you, sir. This is sparkling. So the big problem was that not only it entered inside, the setback happened not only to the vaccination program. The Sanofi person was arrested, the team, and secondly, the setback was the MMR vaccination program. The public, immediately everybody becomes hesitant to all vaccines. So that's why this is one of the lessons to be learned by future vaccine manufacturers. So this was about dengue vaccine. So it is not going to get introduced in India. The Q dengue is the second vaccine which is there. And the best part they have done is they have not taken the yellow fever backbone. They have used N2 and NV2 as the backbone, on which 1, 3 and 4. So they are all similar together. So there is no such thing, and then you need not do a sero status of the person before giving the vaccine. That is the best part of it. The second difference is this also includes the NS1, which was not there in dengue vaccine. So that's why this vaccine has outscored, and as far as safety is considered, if you ask that routinely is it going to be used in India, again the WHO has given clear guideline. How much is the outbreak incidence in your country? Consider that age specific and use it in the program.
So yeah,
Currently, dengue vaccine has been withdrawn. Sanofi is no longer manufacturing it. I think we can just forget. So it's only the Q dengue which is now current. One more very exciting vaccine called the Butantan vaccine, which in India is going to be manufactured under the name of Dengue All. It's a single dose vaccine. It is also a chimeric vaccine. They have taken dengue 1, 2 and 1, 3 and 4. And dengue 2 is 4 base on which they have introduced dengue 2. It has shown almost about 75 to 80% protection in the seropositives and around 80% in the seronegatives, but they have a very short period of follow-up of 18 months. Larger phase 3 studies are going to begin in India very soon. That may be a game changer vaccine, a single dose vaccine as far as dengue is
And what
concerned.
about malaria?
Well, malaria 2 vaccines are currently available. One is called Mosquirix, or also known as RTSS1. This contains a certain part of the genome of the circumsporozoid protein, which is a part of the exoerythrocytic cycle, that has been tagged onto the hepatitis B surface antigen, adjuvanted with AS01. Now, this vaccine has been extensively studied, around 45 to 50% protection against clinical malaria and around 35 to 40% against severe malaria. It is already been rolled out in almost about 14 or 15 African countries, and another 35 to 40 are lined up for it. The other vaccine is called R21. R21 is the same RTS, but they are formulated into nanoparticles, and that has made it much more immunogenic. And this vaccine has given 75 to 80% protection against first episode of clinical malaria. Again, they have a very short period of follow-up. We do not know what will happen on longer term follow-up. Incidentally, both these vaccines are only against falciparum. There is no vaccine against Vivax malaria because Vivax malaria is not as dangerous as falciparum malaria. And the WHO also has set guidelines depending upon what is the annual parasitic index and the falciparum positivity rate in those between 2 to 10. Based on that, they have divided into high intensity, medium and low. And WHO recommends it only for medium and high intensity vaccines.
So moving on to the rabies vaccine, a very common question is cat bites here, and do they require ARV?
Yes. Strictly speaking, any mammalian bite is capable of transmitting rabies. In India, 90% of rabies is by dogs, another 8% by cats, another 2% by other mammals. Cats have the terrible habit of always licking their paws, or saliva is always there in their paws. So whether it's a bite or a scratch, it is taken as a category 3 bite if there is a bleed. It has to be treated just like dog bite only. There is no difference. You have to give local immunoglobulin or monoclonal antibodies and the vaccine like you would do for a dog bite. Remember, we should see these recommendations are for rabies endemic country. India is a rabies endemic country. I don't know what the situation. UAE, I don't think you have rabies. So your criteria will be a little more relaxed. You won't use such strict criteria.
But I think cat bites are being given ARV here. What about pet dogs who are being vaccinated?
Right. Now again, if you look at the WHO recommendations, there is no mention about the vaccination status of the biting animal in deciding what is your protocol for treatment. It is only category 3 and the immunocompetence of the host. Only these 2 factors are taken into consideration. Okay, but if you look at USA, it is much different. There is no endemic rabies except for bat rabies. So in a non-endemic country, you can have more relaxed, where you can have the luxury of waiting and deciding on post-exposure prophylaxis. In India, there was a study done on dogs up to 1 year after they were vaccinated. Only 65% had seroconverted. So the dog rabies vaccine is not as effective as the human rabies vaccine. So from that point of view, in India, even for a pet dog bite, we take it as a exposure and treat it accordingly.
So
I think all of us need to understand before talking about, of course, vaccine and things are important, but monoclonal antibodies. But thorough washing of the site by soap and water for 10 to 15 minutes reduces chances of rabies by 50%. That's a huge number. So I think and that's immediately, everybody can do that, but it has to be 10 to 15 minutes of thorough washing. That is what is important at the bite site.
And sir, you can tell us about the monoclonal antibodies also.
You have?
Just,
So we have 2 monoclonal antibodies which are available in India. So one is called as twin wrap and the other is Vaccination. So these are the 2 monoclonal, both are equally effective. The dose varies on both of them and then the number of monoclonal antibodies are different, obviously 2 different manufacturers, but both are equal. So none is superior to the other one. Whichever is available, we use it.
AB Shield is a human monoclonal antibody, whereas the Zydus vaccine, that is twin wrap, is a humanized murine monoclonal antibody. So that's why you require much higher dose of that and lesser dose of the human. In fact, the human is 3.3, that is 40 units per kg.
So, a 2-year-old boy has been found to have obstructive neuropathy due to PURs. He's gone into CRF and needs transplant within the next 1 to 3 years. What would you do? How do you plan to immunize him before the transplant, after the transplant?
Before the transplant. Before.
Yeah.
Okay. Now, chronic renal failure is an immunosuppressing condition. Okay. The second thing is anyone in chronic renal failure who undergoes dialysis or requires blood products is at very high risk for hepatitis B infection. So in this case, all the other vaccines are fine, but you have to be very careful about the hepatitis B vaccine. You have to give the vaccine, document seroconversion, and if he is undergoing periodic hemodialysis, you have to see that antibody titers have been checked at least once a year, and you have got to give boosters if it falls below the level of protected level of 10 international units for hepatitis B. In any chronic condition where an intervention is being planned, it is always better to complete the schedules before the intervention if you can afford to wait for it. So in this case, whatever routine childhood infections vaccinations are due, they should be completed before you start the dialysis. That is the general recommendation.
Going further, hematopoietic stem cell transplant is contemplated for a 4-year-old with acute leukemia. He received all routine immunization through 2 years of age, but nothing since then. Again, what would be our plan?
Basically, see,
Similar.
It's
variations of the same thing.
total
Next.
marrow ablation. So he is nailed. So you got to restart everything.
So here one thing only to remember is presence or absence of GVHD. There are certain changes as far as GVHD is concerned. Next. So this is before and this is after. Like I said, afterwards it depends whether the child has graft versus host disease. Next. Right, so all live would be contraindicated if GVHD is there. Next. And post-transplant, avoid all polysaccharide vaccines. Administer the 4th dose of your conjugated vaccine. Next. With this, we are done with most of the routinely asked questions, queries that we face, and I thought it was good to highlight. I'll run through certain very basic things which, quickly, all of you all know it, just to revise. Next, lapsed immunization schedule. So intervals between doses that are longer than recommended typically do not reduce the final antibody concentration. So don't keep restarting the schedules. Next, extra doses. Extra doses of many live virus vaccines and grape-borne hepatitis B have not been found to be harmful. This is another thing because a lot of children come to us without record is lost, or it was given in India, or it was given somewhere else, we don't know. So they worry about restarting or giving again. Next. Lapsed vaccination schedule. Suppose they have not taken a lot, you can give them together, not to worry about that.
This is where you use the grace period and try to finish off the schedules as soon as possible when there is a lapsed vaccination schedule.
Okay, that's a very good point to remember. Use the grace period. So, if written records are not available, they should be considered as not received.
Yes.
Okay, that is important. Next. Vaccination for children taking antibiotics. Can we give?
No. Yes, yes.
Yes. Next. If they have antiviral medication.
Only the live influenza vaccine can be given only 48 hours after stopping your
Exactly.
therapy.
Then inactivated can be given live 48 hours after cessation of therapy with antiviral influenza drugs. Next. As you see, this is all from DHA. Vaccination and TB tests, can we do them simultaneously? Injectable live vaccines may be given simultaneously, that means the same clinic date with a TB test. However, if a live vaccine was administered one day before, placing the TST or IGRA should wait for 4 weeks. This is a recommendation. Next. Vaccination of preterm infants.
Chronological age.
How do we plan? Same chronological age, same schedules, same precautions, except. Yes?
Hepatitis B.
Next.
Regarding hepatitis B in a newborn, currently everyone in the world is using 4 doses, hepatitis B plus 3 doses along with the primary schedule, either 6, 10, 14 or 2, 4 and 6. So from that point of view, in 2017, the WHO has come out with a recommendation that irrespective of the birth weight and gestational age, all infants should receive the birth dose of hepatitis B vaccine.
That did not be counted because as it is, we will.
Yeah, these are not contraindications to routine immunization, just revising it again and again because these are the questions people keep asking. So just be rest assured, mild illnesses, multiple vaccines, antibiotic therapy, stable neurological conditions like CP and Down syndrome, history of asthma or eczema and use of inhaled or topical steroids, breastfeeding, preterms, underweight children, allergy to products not present in the vaccine or allergy that is not anaphylactic, pregnant or immunosuppressed person in the household. Here you be little careful, we have already highlighted. Family history of adverse events following immunization, family or personal history of febrile convulsion or epilepsy, precaution only for MMRV, tuberculin skin testing and over the age recommended in the immunization schedule, though the age limit applies to the rotavirus vaccine as we all know. Thank you. That is that will end this session.
Thank you, Dr. Kalpana. Thank you, Dr. Kasi and Dr. Upendra for that lovely informative talk on vaccines.
Yeah, I think we have some more tasks left for all of you.
We are running away.
You are running away. But what time is your flight? So, okay, anyway, I think it was a wonderful session as usual, Dr. Kalpana. There are a couple of things I just wanted to add. I think Rotacil is available in the evening. By the way, serum